Okay, let's unpack this. We are navigating a period of, well, unprecedented scientific revolution in medicine, right?
Absolutely.
Think about it. Our understanding of molecular biology is just skyrocketing. Or developing, curative therapies for diseases that were basically fatal a decade ago.
Yeah, things we never thought possible.
And then looming over it all is the massive predictive power of artificial intelligence, AI, which is training on and interpreting just more patient data than any human could possibly comprehend.
It's dizzying progress, really. But
Yeah.
if we kind of pull back for a second, we realize that amidst all this dazzling technology, the core experience being a patient, of being vulnerable, of being ill, that remains profoundly personal.
Right.
You can have the most advanced AI algorithm, the clearest CT scan.
Right.
But often, the patient's satisfaction, their sense of being cared for, of being on the path to healing, it hinges on something far simpler.
Which brings us straight to that common, really deeply telling complaint you hear. I mean, everywhere, right? In hospital corridors, doctor's
My
offices.
doctor never touched me.
Exactly. It's an expression of dissatisfaction that just cuts right to the heart of the clinical relationship, doesn't it?
It really does.
It suggests that maybe in our rush toward technology, we might be sacrificing that foundational human connection that, defines care.
And that sentiment provides the perfect launch pad for our deep dive today. We are focusing on a crucial, sometimes overlooked section in Harrison's Principles of Internal Medicine. I mean, the authoritative text for the field.
The Bible of internal medicine, basically.
Pretty much. And it's a section that directly challenges this idea that the physical exam is somehow obsolete.
Yeah.
Instead, it argues for the enduring, non-negotiable value of the physical examination, or PE.
Right.
And crucially, how we can apply rigorous science and epidemiological tools to these age-old bedside observations.
Yeah, I find it fascinating that this massive, really cutting-edge textbook dedicates so much analysis not to the latest molecular marker, the fancy new test, but to the simplest tools.
Right.
The clinician's hand, eye, and ear. So our mission today is to understand why this skill remains so crucial and how to use it scientifically.
Definitely. And to truly appreciate the modern scientific approach to the PE, we probably need a little bit of historical context first. The Harrison's text actually reminds us that physical examination skills were hampered for centuries.
Yeah, the early days of medicine were highly constrained, weren't they? Because of these longstanding prescriptions against dissecting the human body, anatomical and physiological understanding was incredibly poor.
Until Vesalius.
Right, until Andreas Vesalius published his foundational work in 1543. Before that, diagnosis was based on really limited observation of the living person.
Exactly. Though Hippocrates, way back in the 5th century BCE, he was kind of a rare exception. He noted signs like, the bulbous enlargement of the fingertips, clubbing in patients with serious chest diseases.
Wow, that far back.
Yeah. And he described the succussion splash, that audible sloshing of fluid and air in the chest, which he could hear just by shaking the patient, long before any instruments existed.
Incredible. But the real revolution, the first time a physician got a tool that allowed them to sort of look inside the living body without surgery. That came much, much later, 1761.
Thanks to Leopold Auenbrugger.
Right, the Viennese physician who invented percussion.
And the story around Auenbrugger's discovery is just a classic example of lateral thinking, isn't it?
The wine casks.
Exactly. He was inspired by his father, who was an innkeeper. His father would tap on wine casks in the cellar, listening for the change in the acoustic pitch to estimate how much wine was still inside.
So Auenbrugger just applied that same principle to the human chest.
He did. Simple as that.
And what he found was revolutionary. He could percuss the chest to detect, say, an enlarged heart, or fluid in the pleural space, or consolidation in the lungs, just by listening for the dullness or the resonance.
Yeah, the authors of the Harrison's text call it the ultrasound of its day, which is a great way to think about it.
It really is.
And what's truly amazing is how complete Auenbrugger's initial work was. Very little fundamental has been added to the art of percussion since then, though, of course, we now have specific descriptive findings like schodaic resonance.
Ah, that's the high-pitched sound above an effusion.
That's the one, that high-pitched sort of arc of hyperresonance you find just above a large pleural effusion, or the narrowing of Kronig's isthmus in apical diseases like TB.
So percussion then kind of spurred the great 19th century instrumental revolution,
That's right. That gave us René Laddick's stethoscope in 1816.
which must have been another game changer.
Huge. Then Hermann von Helmholtz's ophthalmoscope in 1850, allowing us to actually see the retina. The reflex hammer, the blood pressure cuff from Scipione Rivaracci in 1896.
Yeah.
It was really the golden age of physical diagnosis. Everything hinged on meticulous observation.
And nobody embodied that observational prowess better than Professor Joseph Bell at the University of Edinburgh.
Ah, yes, the real-life inspiration for Arthur Conan Doyle's Sherlock Holmes.
That story is incredible, and it just perfectly illustrates the power of inspection alone, doesn't it, before even touching the patient?
It does. So this woman walks into the clinic with a small child, and Bell, one of the most famous observational physicians in history, before even starting palpation or auscultation, he just immediately starts rattling off these specific facts about her life.
Yeah, he asks her if she still worked at the linoleum factory,
Right, and inquired about her crossing from burnt Thailand.
and even asked what she did with the other child. His students, including Conan Doyle, must have been absolutely stunned.
You can imagine. And his explanation is just pure deductive clinical reasoning. He'd noticed her specific Fife accent, right? So he deduced she likely traveled from the nearest Fife town, which was burnt Thailand.
Okay.
He saw traces of red clay on her shoes. And he knew that the only such clay near Edinburgh was at the Botanical Gardens. So he basically mapped her route through the city. He observed that the coat she carried was too large for the child with her, meaning she must have started the day with 2 kids. And finally, she displayed this specific contact dermatitis on her right fingers.
Which was unique to linoleum factory workers in that region.
Exactly. It's the power of the clinical gaze, that inferential skill based on meticulous inspection.
But here's the major pivot the Harrison's text highlights, and it's a bit sobering. With the explosion of modern imaging, labs, automated diagnostics, these essential bedside skills began to decline significantly.
Starting around the 1970s, yeah. It's a documented trend.
And it's an education failure too, isn't it? I mean, when we rely on multiple choice exams instead of directly observing and correcting trainees examining actual patients with known physical findings.
You inevitably reduce the incentive, right? The incentive to develop and perfect these difficult, crucial skills just isn't there in the same way.
So the mission of this deep dive, guided by the authority of Harrison's internal medicine, it's clear: to inject rigor back into the physical exam, moving beyond just ritual and rote.
And focusing on how to use it scientifically as a primary decision-making tool.
Okay, let's start with the non-negotiable reasons this skill remains relevant. Harrison's lays out, 5 essential truths that really anchor the PE in modern practice?
They are absolutely foundational. The first reason is simply this. For a whole host of high-stakes disorders, the bedside findings are the diagnostic gold standard, full stop.
Meaning there's no lab test, no imaging modality that can definitively make the diagnosis.
That's right. The clinician's finding is the definitive test in those cases.
That feels kind of counterintuitive in, 2024.
It does, but it's true. And point 2 connects the PE directly to evidence-based medicine, or EBM, focused evidence-based maneuvers. They actually adjust the probability of disease.
Okay, so this is where we move from sort of qualitative art to quantitative science.
Exactly. Directing and complementing subsequent, often expensive imaging and testing.
Right. Reason 3.
Reason 3 focuses on discovery. The PE is often the first place we uncover clues to other, maybe asymptomatic or unrelated disease states that are potentially treatable. You have to maintain that wide clinical gaze, looking beyond the patient's chief complaint to discover, the whole person's health profile.
Don't get tunnel vision.
Precisely. And reason 4 is a major driver of quality improvement: error prevention.
Ugh.
The authors point out pretty starkly, actually, that missing critical findings because of a cursory exam leads directly to diagnostic delays. It subjects the patient to unnecessary procedures, excessive contrast exposure, radiation, even invasive surgery sometimes.
And that means massive morbidity, malpractice risk.
All of it.
Yeah. Okay, and the 5th reason?
Finally, the 5th reason kind of transcends the science and enters the human realm. The physical examination, particularly when performed well and thoughtfully, functions as a powerful human ritual.
A ritual.
Yeah. This ritual builds confidence, it establishes profound trust, and it validates the patient's experience in a way that just looking at data on a screen never can.
Let's delve into that first point then. Conditions where the physical exam is the gold standard, often requiring minimal or even no technology. It's actually remarkable how many high-stakes diagnoses fall into this category.
Oh, it covers entire disciplines. Take dermatology, for instance. Think about conditions like cellulitis,
Right, the skin infection.
diagnosed by warmth, erythema, tenderness, or psoriasis, eczema, or herpes zoster shingles. These are diagnosed primarily by observation. You look at the morphology of the lesion, you palpate the consistency, and you diagnose. A skin biopsy. That's typically reserved only for diagnostic uncertainty, not for routine confirmation.
So the eyes and hands are the primary tools there.
Absolutely. And the same rigor applies in neurology, where functional deficits are only measurable at the bedside. The Harrison's text specifically flags amyotrophic lateral sclerosis, ALS,
Lou Gehrig's disease.
as a purely clinical diagnosis. There's no imaging or blood test that can confirm it. It's defined entirely by the pattern of upper and lower motor neuron signs found during the neurological exam. And we should note the specific nuance in testing for neuropathy. Traditional nerve conduction studies are great for testing the larger myelinated nerve fibers.
Okay.
But the sensory exam, when you test pain and temperature sensation, that assesses the smaller, unmyelinated nerve fibers. And crucially, the clinical exam for small fiber neuropathy might actually be more sensitive than the technology in some cases.
More sensitive than the nerve conduction study.
Potentially, yes, for those specific small fibers.
And the exam findings are essential for localization too, right? Like figuring out where the problem is in the nervous system.
Oh, absolutely. The pattern of sensory loss is like a clinical GPS. A glove and stocking distribution points to peripheral neuropathy. Radicular pain or sensory loss suggests a nerve root problem. Brown-Séquard syndrome indicates a specific spinal cord lesion and crossed signs.
Where one side of the face and the opposite side of the body are affected.
Exactly. Those are the classic localizers for a brainstem lesion. The exam tells you where to look next.
Okay. What about rheumatology?
Hugely important there too, because serology, the blood tests, are often insufficient. Take rheumatoid factor, or RF. A positive RF alone, without the right clinical features like symmetrical joint involvement or palpable synovial hypertrophy or that prolonged morning stiffness.
It can be misleading.
Frequently falsely positive, yeah.
Mm.
So seronegative rheumatoid arthritis is, by definition, a clinical diagnosis based on these physical findings. You need the hands-on assessment.
Makes sense. And cardiology, you wouldn't think the exam trumps technology there.
Well, consider pericarditis, the inflammation of the sac around the heart. Its diagnosis depends on a combination of characteristic chest pain, hearing that audible friction rub.
With the stethoscope.
Right, and specific EKG changes.
Okay.
But here's the sobering statistic that really undercuts relying solely on imaging. The authors state that somewhere between 34 and 50% of patients with confirmed pericarditis have normal echocardiograms.
Half. Half have normal echoes but still have pericarditis.
Up to half, yeah. So the gold standard in this case remains the patient's clinical presentation and those bedside exam findings. The echo can miss it.
That's a critical point. And finally, a really high-stakes area. The ophthalmology exam, specifically looking at the red eye.
Right. The internist must be able to recognize specific signs that demand immediate ophthalmology referral, because any delay could mean vision loss.
What are those signs?
Things like paralimbic erythema, which we call ciliary flush. It's a deep redness concentrated right around the cornea. Also, acute pain, any vision loss, or the presence of hypopyon.
Which is pus in the front chamber.
That's right. Fluid or pus visible in the anterior chamber of the eye. Seeing any of those means an urgent call to the eye specialist.
And even just simple inspection helps differentiate common causes of conjunctivitis, like pink eye.
Definitely. Bacterial conjunctivitis is typically purulent, sticky, often crusts the eyes shut overnight. Viral or allergic conjunctivitis, on the other hand, usually presents with watery or mucoid discharge, often associated with itching or maybe a history of hay fever. These are all critical, sometimes sight-saving diagnoses resting solely on the clinician's careful observation.
Okay, so this deep commitment to the PE brings us to a fundamental challenge, right? The assumption among many trainees, maybe even practicing docs sometimes, that physical exam findings are unreliable. They're soft.
Yeah, compared to the hard data from a CT scan or a biopsy, which they might see as unimpeachable gold standards.
But Harrison's refutes this pretty strongly.
It does. It makes the point that human observation is fallible in all fields: radiology, pathology, and bedside medicine. It's not unique to the PE.
So we need a way to quantify that human fallibility, that subjectivity. How do we actually measure the agreement between two experts looking at the same sign, whether it's a rash on a patient or, a shadow on an X-ray?
We use the kappa statistic, denoted as kappa. It's the standardized measure of inter-observer agreement, basically. How often two different examiners agree on a finding, but it's normalized against the agreement you'd expect just by chance alone.
Okay, so kappa tells you how much better two doctors are agreeing than if they were just, like, flipping a coin.
Exactly right. Its value ranges from 0, meaning agreement is purely down to chance, up to 1, which represents perfect agreement.
And what's considered good agreement in practice?
Well, for most clinical purposes, a kappa between zero point 0.2 and zero point 0.4 is considered fair. Anything above 0.7 is generally seen as very good agreement.
Now, this is where the data gets really surprising, isn't it? Because it puts image interpretation and even pathology in a different light.
Absolutely. The data presented in Harrison's here is quite illuminating, maybe even a bit shocking for some. For instance, the inter-observer agreement among clinicians, recognizing an infiltrate on a simple chest x-ray.
Yeah.
It's only fair to moderate. Kappa values range from 0.38 to 0.58.
Only fair to moderate for reading a chest x-ray. Wow.
Yeah. And get this. Classifying coronary artery lesions on an angiogram, a highly specialized, high-tech procedure. The inter-observer agreement among experts is only fair, around kappa 0.33.
Wait a minute. So specialists looking at these high-resolution images can only agree about 33% better than chance on classifying major coronary lesions. That really tells you interpretation bias is everywhere, even with the best tech.
It certainly suggests that. And the fallibility extends even to tissue diagnosis. Pathologists looking at liver biopsies show only fair agreement in noting cholestasis, with a kappa of 0.4. They do a bit better on cirrhosis, moderate agreement, kappa 0.59. The point isn't that technology is bad, of course. It's that human interpretation is the common denominator of potential error, regardless of the tool you're using.
Okay, so what about the physical signs themselves? Which maneuvers are actually reliable, and which ones should we maybe, abandon because the agreement is just too low?
That's the key question. The reliability varies enormously. Some signs, like percussing for liver span or using something called auscultatory percussion, they have notoriously low inter-observer agreement.
So they're not reproducible?
Pretty much.
Oh.
And according to the authors, they should simply be abandoned by clinicians because they just aren't reliably reproducible. You can't base decisions on them.
But the text also identifies highly reliable physical signs, ones that we should be teaching and championing.
Yes, definitely. For example, the clock drawing test, a really simple bedside tool for assessing cognitive impairment, has a very good kappa of 0.73. That's solid.
Okay.
And the maneuver we mentioned earlier, eliciting a positive abdominojugular test, which assesses central venous pressure, that has a kappa of 0.92.
0.92, that's almost perfect agreement.
It's incredibly high.
Yeah.
So the lesson is clear. The physical exam isn't inherently unreliable. Its clinical utility depends entirely on what you test and how rigorously you test it. Focus on the proven reliable signs.
Okay, this next section feels like where the PE really transforms from maybe a subjective art into more of an objective applied science. We're talking about iterative hypothesis testing, right? History gives you initial ideas.
And the PE helps you accept or reject them, refining your possibilities. But the process must start with establishing the pretest probability.
Which is what exactly?
It's the baseline risk or probability of the disease being present before you even lay a hand on the patient. Clinicians need to have these probability ranges either memorized or readily available based on the clinical setting and the patient's presentation.
Okay, so give us some examples. What are some of these critical baselines Harrison's mentions?
Well, for a patient presenting with a cough and fever, you should know the baseline probability of pneumonia is somewhere between 15 and 35%.
Okay, that's a pretty wide range.
It is, depends on the patient's age, risk factors, etc. If a patient comes in with acute calf pain and swelling, the pretest probability of a deep venous thrombosis, a DVT or blood clot, ranges from 6 to 43%. Again, depends heavily on their individual risk factors.
And that baseline risk isn't fixed, right? It changes based on where you see the specific patient population.
Exactly right. The text uses hepatopulmonary syndrome, or HPS, which is a lung complication of severe liver disease, as a great example. The overall risk for HPS is maybe 14 to 37% in patients with cirrhosis.
Okay.
But if you see that patient in a primary care setting, the risk is probably at the lower end, closer to 14%. If you see them in a specialized hepatology clinic,
Where they see sicker patients with liver disease.
precisely, the risk jumps closer to 37%. So the context matters hugely before you even begin the exam.
Okay, so you have your baseline probability. Now here's where it gets really interesting and frankly really powerful. The likelihood ratio, or LR. This seems to be the diagnostic weight that lets us rapidly estimate how much a specific physical finding changes that baseline probability.
That's exactly what it is. The LR is the quantification of diagnostic utility for a specific sign. It's calculated as a ratio. The probability of finding that specific sign in someone with the disease, that's the sensitivity, divided by the probability of finding the same sign in someone without the disease, which is 1 minus the specificity.
Okay, sensitivity over 1 minus specificity.
Right. And the interpretation is straightforward. An LR greater than 1 increases your probability of the diagnosis, and LR less than 1 decreases it. And the further away that number is from 1, either higher or lower, the more powerful the sign is diagnostically.
But calculating that ratio at the bedside for every sign seems impractical.
Totally impractical, which is why there's a great rule of thumb popularized by Dr. Stephen McGee that makes this instantly usable in the clinic.
Ah, the shortcut. Tell us about it.
It's brilliant in its simplicity and really quite accurate for clinical decision-making. The rule basically states that LRs of 2, 5, and 10 translate roughly to an increased probability of disease of about 15, 30, and 45% respectively.
Okay. 2 gives you 15%, 5 gives you 30%, 10 gives you 45% increase.
Exactly. And the negative LRs work the same way in reverse. LRs of 0.5, 0.2, and 0.1 reduce the probability by about 15, 30, and 45%.
So 0.5 is minus 15%, 0.2 is minus 30%, 0.1 is minus 45%.
You got it. It's a quick mental conversion that's usually accurate within 5 to 10%, plenty good enough for most bedside decisions.
Let's apply this. Let's use that hepatopulmonary syndrome example again. Say we start with a pretest probability of maybe 30% for HPS in a patient we know has cirrhosis, and during the exam we find finger clubbing. Harrison's assigns clubbing an LR of 4.3 for HPS.
Okay, an LR of 4.3 is pretty close to 5 on McGee's scale. So that finding increases our probability by about 30%.
Right.
So add that 30% increase to our 30% baseline probability, and suddenly we're at roughly 60% probability for HPS. That's a major shift based solely on looking at the patient's hands. But we can keep going. Iterate.
Okay, so what if the patient also has cyanosis, that blueness in the lips or fingers? The text notes that as an independent finding with an LR of 4.4 for HPS.
Okay, another LR around 4 point something, close to 5 again. So that finding adds another 30% increase in probability.
So starting at 30%, clubbing took us to 60%. Now cyanosis takes that 60% and adds another 30%. We're up around 90% probability now.
Pretty much. By combining just those two high-yield physical findings, clubbing and cyanosis, we've driven the post-probability of HPS way up, likely into the 80 or 90% range. We've essentially made the diagnosis at the bedside before ordering any specialized, maybe invasive testing. This justifies ordering the confirmatory tests or maybe even negates the need for other extensive workups.
This quantitative approach seems key to efficiency, too. The authors really emphasize that clinicians should focus their exam time only on findings with LRs outside that 0.3 to 3.0 range. Why is that specific range considered useless?
Because LRs that are close to 1 are diagnostically inert, basically. They don't change the probability enough to matter. An LR of, say, 1.5 only bumps the probability by maybe 5 or 10%. That rarely changes your clinical management plan. You need to hunt for the signs that truly move the needle, the ones with LRs above 3 or below 0.3.
Okay, let's use the example from the text for diagnosing ascites, that's fluid buildup in the abdomen, in someone presenting with abdominal distension. How does this LR principle help focus the exam?
Right, the textbook meticulously compares the LRs of 4 common findings used to assess for ascites. 2 findings significantly increase the probability, the presence of a fluid wave.
Where you tap one side and feel the impulse on the other.
Exactly. That has a powerful LR of 5.0. And the presence of associated edema, like leg swelling, also points towards ascites with an LR of 3.8. Those are the 2 positive findings you really need to look for.
Okay, fluid wave and edema. What are the other common sign? Shifting dullness.
Shifting dullness has an LR of 2.3. See how that falls right into that useless 0.3 to 3.0 range?
Ah, right in the middle, so it doesn't help much.
Exactly. According to this evidence-based approach, we shouldn't waste time meticulously testing for shifting dullness because it doesn't significantly alter the probability.
Okay, so those are the rule-in signs. What about ruling out ascites? Which findings strongly decrease the probability?
Only 2 really matter here. The absence of edema has an LR of 0.2, which is a strong rule-out sign, decreasing probability by about 30%. And the absence of flank dullness, meaning you hear tympany or resonance when you percuss the flanks, have an LR of 0.3, decreasing probability by about 15%.
So the scientifically driven clinician focuses their abdominal exam for a site on just those four specific high-yield findings: presence of fluid wave, presence of edema, and absence of flank dullness or presence of flank tympany.
That's the idea. Maximize your diagnostic yield while minimizing unnecessary low-yield maneuvers. It's about efficiency and accuracy.
Building on this likelihood ratio concept, Harrison's describes a really brilliant visual tool called the diagnostic ruler. This sounds like a way for clinicians to instantly see the most powerful signs for increasing or decreasing the probability of a condition.
That's exactly what it is. It's designed for rapid clinical decision-making, specifically for assessing elevated left heart filling pressures, which is a key indicator of heart failure.
So it's like a cheat sheet for heart failure signs.
Kind of, yeah. It graphically separates the most impactful signs. The right side of the ruler lists those strong positive findings, the ones with LRs of 3 or more. When these are present, you get that guaranteed bump of roughly 30 to 45% in your probability estimate for heart failure.
Okay, let's list those top positive findings from the ruler. They really demonstrate the power of specific maneuvers, don't they?
They do. Leading the pack is the positive abdominojugular test with an incredible LR of 8.0.
8. That's huge. Close to that 45% increase.
Massive. Following that, a displaced apical impulse, where the point of maximal impulse of the heart is shifted laterally, is very high yield, with an LR of 5.8.
Okay.
We also find that just a simple heart rate greater than 100 beats per minute has a strong LR of 5.5. And the classic S3 gallop,
That extra heart sound.
right, has an LR of 3.9. Still a powerful positive indicator, though sometimes subtle and requires skill to hear reliably.
So just to be clear, if a patient you suspect might have heart failure has a positive abdominojugular test, their probability of actually having those elevated left heart filling pressures increases by nearly 45% right then and there, based on that one finding.
Absolutely, it's a game changer at the bedside. Conversely, the left side of the ruler shows the powerful rule-out findings, those signs with LRs of 0.3 or less, which significantly decrease the probability by 15 to 45%.
And what are the strongest negative indicators listed there?
The strongest ones mentioned are the negative abdominojugular test, LR 0.3, and a pulse increment of 10% or greater during the Valsalva maneuver, LR 0.2. Finding either of those makes heart failure much less likely.
Okay, wait, I see a really key, almost counterintuitive takeaway here, which ties back to what you said earlier about the useless LR range. The absence of a high LR sign is often not helpful, is it?
That's the critical insight this quantitative approach provides, and the ruler makes it visually obvious. For example, the S3 gallop has a high LR when present, LR 3.9. But if a patient doesn't have an S3 gallop, the LR for that abscess is actually 0.8.
And 0.8 is right in the middle of that diagnostically useless 0.3 to 3.0 range.
Exactly. So not hearing an S3 doesn't actually help you rule out heart failure in a meaningful way. You absolutely must rely on the absence of the truly powerful rule-out signs, like the negative abdominojugular test, LR 0.3. The diagnostic ruler forces the clinician to be incredibly efficient and scientifically precise about which parts of the exam they emphasize and which parts they, frankly, shouldn't rely on for ruling things out.
Okay, moving beyond just calculating probability, the physical exam also gives us these things called stop rules. What are those?
These are really important. They are evidence-based clinical prediction rules or specific maneuvers that, when satisfied, lower the probability of a serious condition so significantly, often with an LR very close to 0, that the workup can actually safely end right there.
So they tell you when it's safe not to order the expensive scan or test.
Precisely. They are the epitome of efficiency and patient safety when applied correctly. They make a strong case against the sort of reflexive ordering of, say, imaging for everyone with certain symptoms.
Okay, let's review the key powerful examples of these rules that the authors cite.
All right. For a suspected ankle fracture, the negative Ottawa ankle rule has an incredibly powerful LR of 0.1.
Minus 45% probability.
Huge decrease. If the patient satisfies the rule, meaning they have no bone tenderness in specific zones around the ankle and they can bear weight for 4 steps, the chance of a clinically significant fracture is so low that the workup safely stops. You save an unnecessary X-ray.
Makes sense. What about for deep venous thrombosis, DVT?
For DVT, the original Wells score, a score based on clinical risk factors and exam findings if it's 0 or less, that provides crucial risk stratification with an LR of 0.2.
Minus 30% probability.
Right. Now, it's essential to note the text cautions that this low Wells score usually needs to be combined with a negative quantitative D-dimer blood test to fully exclude DVT, especially in higher risk settings.
Okay.
But the clinical scoring mechanism itself dramatically lowers the pretest probability, which actually improves the utility of the D-dimer test, particularly when the D-dimer result might be borderline or equivocal. It helps interpret the subsequent test.
Got it. There's also a unique example involving osteomyelitis, a bone infection, often in diabetic foot ulcers.
Yes, the negative Gobe-to-bone test. This has an LR of 0.2.
How does that work?
The clinician gently probes the base of the ulcer with a sterile blunt instrument. If they fail to feel a rock-hard, gritty base, which is the classic sensation of hitting infected bone, they can safely decrease their suspicion for osteomyelitis quite significantly. This often helps avoid ordering an immediate, expensive MRI scan based just on the ulcer's appearance.
Fascinating. And finally, maybe the most dramatic rule, used for high-stakes neurological emergencies, the HINTS battery for posterior circulation stroke.
This is potentially life-saving. It's a sequence of 3 bedside eye movement tests: head impulse, nystagmus, skew deviation, used in patients who present with acute sustained vertigo.
Okay.
The specific combination of findings known as the HINTS peripheral pattern, that is, a positive abnormal head impulse test, the absence of direction-changing nystagmus, and the absence of skew deviation in this pattern dramatically decreases the probability of a dangerous posterior circulation stroke, with an LR of only 0.02.
0.0. That's almost zero probability increase, practically ruling it out.
It's incredibly powerful. It means you've reduced the probability of that specific type of stroke by nearly 98%. This allows a skilled internist or neurologist to essentially exclude a life-threatening stroke at the bedside in the right clinical context, often guiding the emergency department's immediate workup and preventing unnecessary, urgent, and costly imaging in patients with benign causes of vertigo.
Okay, this next section really emphasizes the rewarding, almost detective work aspect of the physical exam. The author stressed that maintaining a wide clinical gaze is essential, right? Moving beyond just a narrow exam focused only on the chief complaint.
Absolutely. Failure to adopt this wide scope is really a clinical disservice. The observant physician frequently stumbles upon consequential, maybe asymptomatic clues that can lead to life-saving or at least quality-of-life-improving treatments for conditions the patient didn't even know they had.
Let's start with observing the patient's movement before they even reach the exam table. Gait observations. These seem incredibly informative.
They really are. The text highlights 3 critical, distinct abnormalities we absolutely must recognize. First, the coxaldic gait. This is the classic lateral lurch, where the patient's trunk leans dramatically over a painful hip while they're bearing weight on that side. It's a clear compensatory mechanism to reduce pressure on the painful hip joint.
Okay, leaning over the painful hip. Then there's the Trendelenburg gait, which sounds similar, but you're saying it's mechanistically distinct.
It is distinct. In the Trendelenburg gait, the lateral lean might be less dramatic, but it's defined by a telltale drop in the contralateral pelvis. The opposite hip drops down when the patient steps onto the affected leg.
Why does that happen?
It indicates specific weakness of the hip abductor muscles on the standing side, primarily the gluteus medius muscle. We often see this nowadays in patients who had polio years ago, or, critically, sometimes after surgical damage to the superior gluteal nerve, which can happen during a lateral approach hip arthroplasty, a common type of hip replacement surgery.
So watching someone walk can give clues about past surgeries or neurological issues.
Definitely. And finally, circumduction. This is where the foot swings out in a semicircle rather than moving forward directly in a straight line.
What does that suggest?
This classic finding often suggests prior hemiplegia, maybe from a stroke, where the leg muscles are stiff or spastic, making it hard to clear the foot during the swing phase of gait. So these 3 examples just show how much information is available simply by watching a patient walk into the room.
Incredible. Okay, moving from gait to faces and expressions. These observations can immediately suggest systemic, maybe chronic disease.
Yes, the text lists some striking examples, like the hatchet face seen in myotonic dystrophy, which results from profound wasting of the temporal and facial muscles. It's a very distinct appearance.
Okay.
We can sometimes spot the characteristic blue-gray pigmentation around the malar region, the cheeks, which is indicative of amiodarone use, a common medication for heart rhythm disorders.
Ah, a medication side effect visible on the face.
Right. Another vital clue mentioned is the presence of mucosal neuromas, these small, bumpy tumors on the lips and tongue. Seeing those is almost pathognomonic, meaning specific for multiple endocrine neoplasia type 2B, or MEN2B. That's a syndrome requiring urgent screening for associated cancers, like medullary thyroid cancer. Finding those bumps can be life-saving.
Wow. Okay, the section on hands and skin also provides essential focus. We are warned, interestingly, against getting too hung up on most of those eponymous nail changes, Beau's lines or Terry's nails.
Yeah, because while they sound specific, they're actually quite common findings associated with multiple, often vague systemic conditions like renal failure, liver failure, malnutrition, severe illness. They lack diagnostic specificity.
So the focus must be on high-yield, more specific signs on the hands and skin.
Exactly. For suspected endocarditis, an infection of the heart valves, you actively look for Osler's nodes or Janeway lesions on the palms and soles. For chronic liver dysfunction, you look for palmar erythema, red palms, and maybe those white nails. Terry's nails, though less specific.
And neurologically?
Neurologically, classic findings like a wrist drop immediately suggest a radial nerve palsy. A claw hand deformity points strongly towards an ulnar nerve palsy. These signs can localize the neurological problem instantly, right there at the bedside.
And let's not forget the power of smell, the olfactory sense. Odors can apparently be pathognomonic, providing immediate, crucial diagnostic information.
Indeed. It's an underutilized sense in modern medicine, perhaps. But we must train ourselves, or at least be aware of, specific disease-defining scents. The text mentions the sort of sweet grape-like odor of a Pseudomonas wound infection.
Okay.
The uriniferous smell, like ammonia, in severe renal failure or uremia. Or the similarly ammoniacal, sometimes described as mousy, odor associated with hepatic failure or liver failure.
And the one everyone learns in medical school?
The fruity acetone-like scent of diabetic ketoacidosis, or DKA,
Yeah.
that's caused by volatile ketone bodies being exhaled, and recognizing it is a life-saving clue that demands immediate action. There's also the rare but critical bitter almond scent associated with cyanide poisoning.
So our noses can be diagnostic tools, too.
They absolutely can be. And finally, even simple observation of clothing and accessories offer surprisingly deep clues sometimes.
How so?
Well, inappropriate clothing for the ambient temperature can be a subtle clue. Someone wearing multiple layers on a warm day might suggest hypothyroidism. Someone wearing very little on a cool day might suggest hyperthyroidism.
Huh, makes sense.
Obvious neglect in clothing or mismatched colors or styles might signal underlying dementia or delirium, especially in an elderly patient. But perhaps the most immediate practical clues are things like untied shoelaces or shoes where the toes have been deliberately cut out.
Why would someone do that?
Often it indicates chronic, severe edema or painful gout flares, making it impossible for the patient to wear their standard footwear. It tells you something significant is going on with their feet or fluid status. The clinical gaze really integrates every single piece of information available, from head to toe, including what the patient is wearing.
Now, the flip side of great observation is, unfortunately, catastrophic oversight. Harrison's provides some pretty sobering, real-world examples of misdiagnoses that happen because of an incomplete or superficial exam.
They do, and they serve as important warnings. The most dangerous examples often involve missing signs of serious infection. For instance, missing tiny petechiae or larger ecchymosis, bruises, because the patient's clothing wasn't completely removed during the exam.
And that could lead to fatal delays in diagnosing.
Conditions like Rocky Mountain spotted fever or meningococemia, both of which require rapid antibiotic treatment to prevent death or severe disability. You have to look everywhere.
That's terrifying.
Or consider the patient who gets sent down a long, expensive path of testing for maybe systemic vasculitis or some kind of seronegative arthritis. They see multiple consultants, get tons of blood tests, maybe imaging, only for someone eventually to finally look closely at their hands and feet and note obvious finger clubbing. Or maybe you notice a subtle Horner syndrome, a droopy eyelid and small pupil. These findings could immediately suggest pulmonary hypertrophic osteoarthropathy,
Which is often caused by
an underlying previously unrecognized lung malignancy. The joint pain was a paraneoplastic syndrome, a clue to the cancer, missed because the basic exam wasn't thorough.
Wow. Or the examples of patients sent for cardiac catheterization for chest pain.
Right, sent urgently to the cath lab for presumed acute coronary syndrome, a heart attack, when the true diagnosis was actually a subtle, maybe easily missed vesicular rash, classically described as looking like dewdrops on rose petals, involving a dermatome, a strip of skin on the chest,
Indicating.
herpes zosters, or shingles. The chest pain was neuropathic pain from the shingles outbreak, not cardiac pain. A careful skin exam would have prevented an unnecessary, invasive, and expensive procedure.
These are truly errors of omission, aren't they? And it's compounded by the fact that technology, like radiology, isn't always superior, as you mentioned.
Exactly. The text points out that radiologists frequently report surgical emergencies, like a strangulated bowel seen within a hernia, or Fournier's gangrene with gas visible in the scrotal tissue on plain X-rays or CT scans that were taken the day after the patient was admitted.
Meaning?
Meaning these were, by definition, surgical emergencies that should have been obvious on physical examination when the patient was first assessed in the emergency room or on the ward. The exam findings were likely missed or misinterpreted initially.
And the physical exam must also be used sometimes to challenge or correctly interpret imaging results, right? Even with urgent neuroimaging, like for an acute third cranial nerve palsy, the clinical rule of the pupil remains paramount.
It's absolutely crucial. It's based on the anatomy and pathophysiology of the third nerve. A dilated, non-reactive pupil in the context of a third nerve palsy strongly suggests a compressive etiology, typically a posterior communicating artery aneurysm.
Why is that?
Because the parasympathetic nerve fibers controlling the pupil run along the surface of the third nerve, so they get compressed first by an external mass like an aneurysm. A normal reactive pupil, on the other hand, suggests an ischemic cause, like diabetic neuropathy, because the tiny blood vessels supplying the core of the nerve are affected, usually sparing those superficial pupillary fibers.
So pupil involved suggests compression, aneurysm. Pupil spared suggests ischemia.
Generally speaking, yes. And the authors highlight cases where sticking to this clinical rule saved the patient. One patient had a scan initially read as possibly showing a mass causing the third nerve palsy, but because the pupil was spared, the clinicians suspected ischemia, held off on invasive procedures, and the palsy resolved on its own.
And the opposite.
Another patient had an abnormal dilated pupil suggesting an aneurysm, but the initial CT angiogram was read as normal. Because the clinical exam finding the blown pupil was so strongly suggestive of compression, the clinicians pushed the radiologist to restudy the images carefully. Lo and behold, a small posterior communicating artery aneurysm was eventually found and treated. The clinical finding correctly superseded the initial technological report.
That's incredible. It really underscores the power of clinical judgment integrated with the exam.
But the source notes that these kinds of errors, missed findings, misinterpretations frequently happen simply because the exam was cursory, rushed, or maybe more insidiously in the modern age of the electronic medical record.
Uh-oh.
The cut and paste functions allow clinicians to artificially import previous exam findings or click through templates, suggesting a complete exam was done when maybe it wasn't or wasn't done thoroughly.
Yeah.
And the rapid turnover of patients, multiple handoffs between providers.
Yeah.
These just magnify the potential consequences of a poor or incomplete initial assessment.
Okay, finally, let's return to the human side of this. The physical examination as a ritual. The authors frame the patient encounter as a deeply vulnerable act for the patient.
It really is. You have a stranger presenting themselves, often feeling unwell, anxious. They're revealing sensitive personal information, and then they physically disrobe, allowing touch and manipulation by the physician.
It's definitely not a normal social interaction.
Not at all. And the physician's great privilege is that this potentially awkward act is accepted as part of the contractual agreement of care. To an ethnographer, someone studying cultural practices, this act of the PE is a ritual. It's defined by crossing a threshold from the waiting room to the exam room, by commitment, the patient agreeing to the exam, and by the goal of transformation, from illness towards wellness.
It signals the patient's shift from maybe trying to manage on their own to actively seeking help.
And critically, it involves the placement of profound trust in the physician.
And patients are expert judges of this ritual, aren't they? They can tell immediately when the examination is just perfunctory.
Oh, instantly. A stethoscope placed briefly over clothing, a quick prod of the belly without genuine engagement or explanation. Patients sense that lack of care.
Whereas a well-performed exam,
When the ritual is performed well, it preserves the patient's dignity, it affirms their humanity, and it validates their symptoms by actually localizing them on their body, connecting their subjective feeling to an objective finding, rather than reducing them to just an abstract lab number or a grayscale image on a screen.
and this ritual, when performed with care and skill, actually has a measurable physiological impact.
Yes, this is the fascinating part about the placebo effect, or maybe better term, context effects, without needing an actual placebo pill. When the context, the clinic setting, the white coat, the ritual itself, and the manner of execution are all performed well, Think careful touch, focused eye contact, detailed palpation, clear explanation. It can induce measurable positive psychobiological effects.
Like actual changes in the body.
Yes, including measurable changes in neurotransmitter levels like endorphins and modulation of pain pathways. Conversely, a clumsy, rushed, or indifferent examination can create the opposite, a nocebo effect,
Meaning a harmful effect.
a harmful psychological reaction that can actually increase anxiety, decrease trust, and potentially impair subsequent interactions and even the effectiveness of prescribed treatments. The way we perform the exam matters physiologically.
The conclusion here seems profound. We absolutely must prioritize having good role models who can demonstrate proper technique and provide direct constructive feedback at the bedside.
We must. And we have to lament the erosion of traditional bedside rounds, which have often been replaced by conference room data review sessions. Because these essential physical exam skills, both the technical and the humanistic aspects, are learned primarily through lengthy apprenticeship and direct, skilled observation and practice. You can't learn them well just from a book or a video.
So where does this leave us now? How does this perspective from Harrison's hold up with recent evidence and guidelines?
Well, the authoritative position taken by Harrison's that integrating evidence-based medicine principles into the physical exam is vital is actually being increasingly confirmed and formally integrated across clinical guidelines worldwide.
So we're seeing professional societies in these high-stakes environments actually adopting these quantitative prediction rules, like the ones we discussed, as standard practice.
Absolutely. Over the last decade or so, major organizations like the American Heart Association, the American College of Emergency Physicians, the Society for Vascular Surgery, they have formally integrated many of these quantitative scores derived from the physical exam.
Like the Wells criteria for DVT.
Exactly. The Wells criteria, the Ottawa rules for ankle and knee fractures, the Hintz battery for stroke evaluation.
Yeah.
These are now embedded in many official diagnostic guidelines and algorithms.
So this institutional adoption really validates the Harrison's text's emphasis on likelihood ratios and clinical prediction rules as being non-negotiable bedside tools today.
It absolutely does. It shows this isn't just an academic exercise, it's changing practice.
And this whole philosophy, it traces its roots back to the late clinical epidemiologist Alvin Feinstein, right? His work seemed highly influential here.
Immensely influential. Feinstein, often considered one of the fathers of modern clinical epidemiology and evidence-based medicine, always stressed that EBM isn't just about technology or large randomized trials. It is, perhaps more fundamentally, about the careful collection and interpretation of clinical data.
Which includes the physical findings.
Yes, but also the physician's unique understanding of the patient's history, their background, social context, work environment, beliefs, preferences, all that holistic contextual data. This is the vital human information that, frankly, no automated algorithm or standalone lab result can ever fully capture or interpret correctly.
And this isn't a static field either, is it? This work of refining the evidence for the physical exam is ongoing.
Definitely. Resources like the excellent JAMA Rational Clinical Exam series and similar publications continue to update the evidence. They constantly scrutinize and refine the data behind various bedside findings, ensuring that the scientific basis for the physical exam remains current, defensible, and relevant to modern clinical care. The science keeps moving forward.
Okay, so let's wrap this up. What does this all mean for you, the modern clinician listening, or maybe the student, or even just the interested learner? It seems clear the physical examination is far, far more than just a routine check.
Absolutely. It's a sophisticated, evidence-based diagnostic tool and an indispensable human ritual. It means we have to cultivate not only the technical skill, but also that deep curiosity required to truly read the body, as some have put it.
We've covered a lot of ground pulling directly from this key section in Harrison's. Let's try to distill the key takeaways that should really guide practice going forward. First, the physical examination remains the diagnostic gold standard for multiple high-stakes diseases. We mentioned Parkinson's, ALS, pericarditis, many skin conditions. This proves its continued indispensable value even when advanced imaging is available, because imaging often falls short in these specific cases.
Second, we learned the reliability of PE maneuvers varies widely. But by using quantitative measures like the kappa statistic, we can confidently identify and rely on highly reliable, high-yield signs, like that abdominojugular test, while consciously abandoning low-yield practices, like trying to percuss the liver span accurately. Focus on what works.
Third, Likelihood ratios, LRs, are the key to transforming the PE into an applied science. They allow for precise, evidence-based adjustments to your diagnostic probability right there at the bedside. And crucially, the clinician must focus only on those signs with LRs outside the diagnostically useless zero point 0.3 to 3.0 range. Don't waste time on signs that don't move the needle.
Fourth, those bedside stop rules, like the Ottawa rules for fractures, the Wells criteria for DVT, the Hintz exam for vertigo, are incredibly important. They are highly sensitive maneuvers that, when negative in the right context, dramatically decrease the probability of serious conditions, which improves both efficiency by reducing unnecessary testing and enhances patient safety.
Fifth, the physical exam demands that the clinician maintain a wide clinical gaze. You have to actively search for those consequential, sometimes incidental clues in the patient's gait, their odor, their clothing, their hands, clues that might indicate unsuspected but treatable systemic diseases. Think like Professor Joseph Bell, using deductive reasoning based on observation.
And finally, sixth, we can't forget the human element. The physical exam, when performed thoughtfully, respectfully, and with deep engagement, acts as a crucial healing ritual. This ritual builds profound trust between patient and physician. It affirms the patient's humanity, and it exerts measurable positive physiological effects, that placebo effect without a placebo, which is a fundamental and often underestimated part of the therapeutic process itself.
So here's a final thought to leave you with. In a future that seems increasingly dominated by artificial intelligence interpreting vast virtual data sets, perhaps the physician who masters the evidence-based physical examination, the one who can expertly synthesize all the data, both digital and human, and still connect through the deeply personal human ritual of touch, perhaps that physician will not only provide the highest quality of care, but will actually be the most valuable and the most needed guide for the patient navigating illness. You, the listener, hold the power and the responsibility to keep this essential science and this essential humanity alive and absolutely central to the practice of medicine.